For Psychopharm Archive, I am a consultation-liaison psychiatrist and academic physician. Case file 003. The patient. He was 25 years old, and he had been in the medical intensive care unit for 3 days when the consultation-liaison psychiatry team was called. He had a diagnosis of autism spectrum disorder and intellectual disability. The technical DSM-5-TR diagnosis reads as autism spectrum disorder, requiring very substantial support for deficits in social communication and requiring very substantial support for restricted repetitive behaviors, with accompanying intellectual impairment, with accompanying language impairment, no intelligible speech, and a comorbid diagnosis of intellectual developmental disorder, profound. For 9 years, he had lived in a residential group home that specialized in adult care for individuals on the autism spectrum, where the staff knew the route through the corridor he preferred at night, knew the foods he tolerated and the foods he would refuse, knew the small laminated card he kept in his shirt pocket with 3 telephone numbers on it that he could neither read nor dial but had not been without since the year he turned 18. The first number was his parents', the second was the group home, the third was his older sister. He had been stable enough on his maintenance regimen of risperidone, 1 milligram twice daily, prescribed years earlier for behavioral management, that his parents had begun to consider whether he might return home. The home trial had begun in late summer. He went back to live with his parents. The first weeks had been unremarkable. By early autumn, the staff at the group home, who had remained in contact with the family, began to hear that he was sleeping less. By mid-autumn, he was no longer sleeping reliably at night. By the time his parents brought him to the emergency department in late November, he had been waking screaming most nights for several weeks, refusing food intermittently, and pacing his bedroom for hours at a time. The week of admission, he had become physically aggressive in a way that was new for him. He had no recent medication change. He had no known recent infection. There was no obvious environmental trigger beyond the original disruption of the home trial itself, which had now been in place for nearly 3 months. In a patient who is nonverbal, with profound communicative impairment and a long-standing pattern of stereotyped motor behaviors, the differential for new-onset agitation is broad, and the clinical signal is weak. Pain, infection, gastrointestinal distress, sleep disruption, environmental change, primary psychiatric decompensation, and catatonia can each present in approximately the same way at the bedside. The literature on catatonic features in autism is real and growing. Wing and Shah, Dosha, Wachtel, and others have documented both the prevalence and the diagnostic difficulty across more than 2 decades. But the overlap between catatonic phenomena and baseline autistic stereotypy makes prospective bedside differentiation in any individual patient extraordinarily difficult. On the night of admission, no one was thinking about catatonia or the nuances of environmental stressors. They were thinking about a man who had become unmanageable at home. The presentation. In the emergency department, he was triaged as severe agitation in a patient with a developmental disorder. He required 4-point restraints to permit a basic medical workup. His vital signs at triage included a temperature of 101.3 degrees Fahrenheit, a heart rate in the 110s, and an oxygen saturation that, on room air, was unexpectedly low for a young man with no known cardiopulmonary disease. The chest radiograph, obtained because of the saturation, was not normal. There was a right lower lobe consolidation. He had pneumonia. The interpretive question this raised, which would not be answered during the admission and probably could not have been, was about sequence. Patients with severe autism and pneumonia commonly present with agitation, particularly when they cannot describe pain or dyspnea. Patients with weeks of agitation and disrupted oral intake commonly aspirate. Either of these findings on the night of admission could be the cause of the other. They could each be the manifestation of a third process. The relationship between the medical and psychiatric features of presentations like this one is not always recoverable from the chart. He was admitted to the medical intensive care unit because the combination of severe agitation, hypoxemia, and the need for sustained restraints exceeded what could be safely managed on a general medical floor. Empiric antibiotics were started. The agitation was managed with intravenous antipsychotic medication. Over the first 3 hospital days, he received intramuscular and intravenous haloperidol totaling approximately 25 milligrams, plus oral and intramuscular olanzapine totaling approximately 20 milligrams, both layered on top of his outpatient risperidone, which had been continued without dose change. The cumulative dopamine D2 antagonist exposure across these three molecules, calculated in chlorpromazine equivalents, was substantial. By the morning of hospital day 4, his agitation had begun to abate. He was quieter, he was opening his eyes intermittently. He had not pulled at his lines. The ICU team noted in the morning sign-out that the antipsychotic regimen was achieving its intended effect. The consultation-liaison psychiatry team was called for transition planning. The collapse. The consultant arrived at the bedside on the afternoon of hospital day 4 with his team. What he saw did not match the ICU team's assessment. The patient's eyes were closed. His head was turned to the side. He was bradykinetic. He was moving his legs intermittently within the restraints in a pattern that was difficult to characterize, too irregular for the agitated motor restlessness that had brought him to the ICU, too persistent for genuine sedation. His arms, when the consultant lifted them within the restraints, felt stiff. His vital signs at that hour were recorded as normal. His temperature, his blood pressure, and his heart rate were all within range. This is the diagnostic moment that determines the trajectory of cases like this one. By any chart-based metric, the patient was improving. The medical record contained no temperature spike, no tachycardia outside expected ranges, no laboratory derangement. The clinical examination, however, was demonstrating something that the chart was not yet showing: stupor with retained motor restlessness, bradykinesia in a patient who 4 days earlier had required 4-point restraints, rigidity that was neither Parkinsonian in its character nor spastic in its quality. At the bedside on the afternoon of hospital day 4, the motor domain was notable. The autonomic domain and the laboratory domain were not. They would be by evening. The consultant recommended discontinuation of all antipsychotic medication. Risperidone, held. Haloperidol, held. Olanzapine, held. The orders were entered. The team left to round on other consults. The consultant returned to his workroom and began checking the chart at intervals of 30 to 60 minutes. 3 hours later, the vitals changed. His temperature was 40.2 degrees Celsius. His blood pressure was 180/110. His heart rate was in the 120s. The consultant returned to the bedside. The clinical picture had now become unambiguous. The limb rigidity that had been subtle on the previous examination was now lead pipe across the major joints. The severe truncal and chest wall rigidity was sufficient that the patient's oxygen saturation, which had recovered with treatment of the pneumonia, had drifted back into the low 90s on supplemental oxygen. The bladder on bedside ultrasound contained over 600 milliliters of urine, autonomic dysregulation expressed as urinary retention, a finding that is sometimes the first sign and is, in this syndrome, easily missed in a patient already in restraints. The diagnosis was neuroleptic malignant syndrome. The DSM-5-TR diagnostic criteria for neuroleptic malignant syndrome, set out in the section on medication-induced movement disorders, require recent exposure to a dopamine receptor antagonist or rapid discontinuation of a dopamine agonist, severe muscle rigidity, and hyperthermia documented as oral temperature above 38 degrees Celsius on at least 2 occasions, with at least 2 of the following associated features: diaphoresis, dysphagia, tremor, incontinence, altered level of consciousness ranging from confusion to coma, mutism, tachycardia, elevated or fluctuating blood pressure, leukocytosis, and laboratory evidence of muscle injury such as elevated creatine kinase. The diagnosis additionally requires that the clinical picture not be better explained by another medical, neurological, or psychiatric condition. There is no laboratory test that confirms the syndrome. The diagnosis is made at the bedside. This patient met every criterion. He had received cumulative parenteral and oral dopamine antagonism across 3 molecules, risperidone, haloperidol, and olanzapine, over the preceding 72 hours. His rigidity was lead pipe in both distribution and severity. His temperature was 38.9 degrees Celsius and would be confirmed on serial readings. The associated features were not subtle: diaphoresis, tachycardia in the 120s, blood pressure of 180/110, mutism, leukocytosis on the complete blood count, metabolic acidosis on the arterial blood gas, urinary retention on bedside ultrasound, and a creatine kinase in the tens of thousands. The pneumonia, identified on admission and already responding to antibiotics, did not account for the rigidity, the rhabdomyolysis, or the autonomic profile. The remaining differential for hyperthermia with rigidity and altered mental status, sepsis, malignant hyperthermia, anticholinergic toxicity, serotonin syndrome, malignant catatonia of non-pharmacologic origin, lithium toxicity, was either excluded by exposure history or did not produce the constellation now in front of the team. There is a clinical instrument for cases like this one, the Yacoub-Francis NMS rating scale, developed by Adib Yacoub and Andrew Francis at SUNY Stony Brook in 2004. It was subsequently validated in the years that followed. The scale breaks neuroleptic malignant syndrome into 23 items across 4 domains: motor, behavioral, autonomic, and laboratory. It is not a diagnostic instrument. It is a severity instrument used at the bedside to quantify a syndrome whose clinical features evolve at different rates and whose recognition often depends on abnormalities in one domain before the full syndrome is evident. The laboratory results fit the textbook profile: creatine kinase in the tens of thousands, leukocytosis, a change in the platelet count, a metabolic acidosis on the arterial blood gas, low serum iron, a finding described in NMS since the early 1990s, Rosebush and colleagues among the first to characterize it, and whose mechanism remains incompletely understood. Every component of the syndrome that can be measured was present. The patient's antipsychotics had been stopped 3 hours earlier. The syndrome had not stopped with them. The mechanism. To understand why the syndrome continued to evolve after the offending agents had been discontinued, we have to begin with the pharmacokinetics of the molecules that triggered it and the pathophysiology of the cascade they had set in motion. Haloperidol has a serum half-life of approximately 20 hours, olanzapine approximately 30. Risperidone, with its active metabolite paliperidone, has effective central D2 occupancy that persists for substantially longer than the parent compound's serum measurements alone would suggest. The discontinuation of all 3 molecules at the same hour does not produce an immediate restoration of dopaminergic signaling. It produces the slow decay of an antagonism that has already saturated the receptor field and triggered downstream effects whose own kinetics are slower still. NMS, once initiated, has its own momentum. The syndrome can progress for hours to days after the offending agent is stopped, because the cascade it represents is no longer dependent by that point on the continued presence of the drug that started it. To understand the cascade itself, we have to begin with the dopamine D2 receptor and acknowledge that the molecules that block it do not have spatial discrimination. Haloperidol is a butyraphenone antipsychotic with high affinity for the dopamine D2 receptor. Its dissociation constant at D2 has been reported in the low single-digit nanomolar range across receptor binding studies dating to Seaman and colleagues' foundational work in the 1970s and 1980s. When administered intramuscularly or intravenously, peak serum concentrations occur within 30 to 60 minutes, and the drug crosses the blood-brain barrier readily, achieving brain-to-plasma ratios that have been reported in autopsy and PET imaging studies at approximately 10 to 1. A single parenteral dose of haloperidol in a patient not previously exposed produces near-total D2 receptor occupancy within an hour. Repeated dosing across several days produces sustained, near-total occupancy across every anatomical region in which D2 receptors are expressed. The clinical significance of that statement depends on a fact that is sometimes elided in pharmacology teaching. D2 receptors are expressed in functionally heterogeneous regions, and suppressing them simultaneously across all of those regions does not produce a single coherent clinical effect. It produces several effects at once. Some are intended, most are not. D2 blockade in the mesolimbic pathway is the intended therapeutic mechanism for the treatment of positive psychotic symptoms, and in this patient for the suppression of severe agitation. D2 blockade in the mesocortical pathway worsens negative symptoms and cognitive output. D2 blockade in the tuberoinfundibular pathway disinhibits prolactin release. D2 blockade in the nigrostriatal pathway produces the Parkinsonian and dystonic features of the extrapyramidal spectrum at full occupancy sustained over time in a vulnerable individual with insufficient compensatory mechanisms. This same nigrostriatal blockade produces something more. The classical neuroanatomical model of neuroleptic malignant syndrome, articulated most clearly by Karoff, Mann, and colleagues across a series of publications beginning in the 1980s, frames the syndrome as the consequence of acute dopamine hypofunction in 2 regions of central importance. The first is the nigrostriatal system, where the loss of inhibitory dopaminergic tone produces the severe rigidity that defines the syndrome clinically. The second is the preoptic area of the hypothalamus, where dopamine participates in the central regulation of body temperature, and where its blockade shifts the thermoregulatory set point upward, These two effects taken together produce a thermal crisis. Sustained isometric muscle contraction generates heat at the periphery. Disrupted central thermoregulation prevents that heat from being dissipated. Core body temperature rises. At core temperatures above 40 degrees Celsius, sarcolemmal membranes lose integrity, intracellular calcium handling becomes dysregulated, and skeletal muscle cells lyse and release their contents into the circulation. Creatine kinase rises, myoglobin rises, the myoglobin precipitates in the renal tubules. Acute kidney injury follows. This is rhabdomyolysis. The patient's CK at first measurement was in the tens of thousands. The autonomic instability, the tachycardia, the labile blood pressure, the diaphoresis, the urinary retention, is best understood in this model as a downstream consequence rather than a primary feature. It is what the autonomic nervous system does when central regulation has failed and the body is in metabolic crisis. This central-dopaminergic model is clinically useful. It is not complete. It does not adequately explain why some patients develop the syndrome while others, on identical agents at identical doses, do not. It does not explain why the syndrome is more common with rapid parenteral dosing than with steady oral dosing at the same total daily exposure. And it does not fully account for evidence suggesting that peripheral mechanisms contribute as well, including a hypothesis advanced by Guerrera and others that NMS shares features with malignant hyperthermia at the level of skeletal muscle calcium handling, and that the syndrome may be driven, in part, by a primary defect in sympathoadrenal regulation rather than through a purely central pathway. Several risk factors have been replicated across the surveillance literature: high-potency typical antipsychotics, parenteral administration, rapid dose escalation, polypharmacy across multiple D2 antagonists, dehydration, physical restraint, intercurrent infection, and male sex. This patient had every one of them. There is one further consideration in this case. The literature on NMS in patients with autism spectrum disorder and intellectual disability, including work by Wachtel and others, suggests that this population may carry elevated risk for both NMS and catatonia, with the boundary between the two conditions in this population sometimes more porous than in neurotypical patients. The mechanisms are debated. The clinical implication is not. In an autistic adult exposed to multiple high-potency D2 antagonists during an episode of agitation, the syndrome the clinician must rule out is, until proven otherwise, this one. The impasse. The treatment of NMS, once the diagnosis has been made and the offending agent stopped, follows a stepped algorithm. Supportive care first, cooling, fluids, electrolyte management, mechanical ventilation if respiratory compromise demands it, benzodiazepines both for the GABAergic deficit hypothesized to contribute to the syndrome and for the muscle relaxation they provide at the spinal cord level, dopamine agonists, bromocriptine or amantadine, to attempt to restore the central dopaminergic tone whose loss precipitated the cascade, dantrolene acting at the ryanodine receptor on the sarcoplasmic reticulum of skeletal muscle for refractory hyperthermia and rigidity that have not responded to the steps preceding it. In this patient, the algorithm was applied: aggressive cooling, IV fluids, and ICU level monitoring. Lorazepam was started at 2 mg and escalated to 2 mg 3 times daily. Within the first day on this regimen, he was profoundly oversedated. He was no longer rousable. His respiratory effort was reduced to a degree that raised concern about ventilatory compromise on top of the chest wall rigidity that had already been narrowing his oxygen saturation. The lorazepam was reduced to 1 mg 4 times daily, which restored a more workable level of consciousness without abolishing the muscle relaxation. Dantrolene was added. Over the 72 hours that followed, the syndrome stabilized. The temperature returned to normal. The vital signs improved. The creatine kinase trended downward. The rigidity softened. The autonomic and laboratory domains of the Yacoub-Francis scale, which had been at near maximum at the time of diagnosis, came down. The motor domain lagged behind. He remained essentially unresponsive. The autistic stereotypes that had been part of his baseline presentation did not return. He did not open his eyes consistently. He did not track his parents when they sat at the bedside. He did not vocalize. He was no longer dying. He was also not recovering. This is the impasse that gives NMS cases their weight when they progress past the standard treatment algorithm. The dopaminergic system that was acutely blockaded has been allowed to recover. The rigidity and the heat have abated. But the central nervous system, having been pushed past the threshold at which the syndrome announced itself, does not necessarily reset on its own. And the longer it does not, the more the clinical picture begins to resemble malignant catatonia rather than resolving NMS. with the boundary between the two conditions shifting from a question of nomenclature to a question of treatment. In cases like this one, and the published literature on this question is small but consistent, the next intervention is electroconvulsive therapy. The case for ECT in refractory NMS rests on the same logic that supports it in malignant catatonia, with which NMS shares a substantial phenomenological and possibly etiological overlap. The early case reports date to the 1980s. The modern literature, including reviews by Trawler, Sachdev, and colleagues, identifies ECT as the most reliable intervention for cases of NMS that do not resolve with discontinuation, supportive care, benzodiazepines, and dopamine agonists. The mechanism by which ECT achieves this is not fully understood. The empirical signal across the catatonia spectrum is consistent. The decision was made to proceed. The aftermath. The ECT was administered by a colleague of the consultant whose practice was focused on electroconvulsive therapy and who had managed cases like this one before. The patient received an initial induction series over the span of several days. The response was rapid. His eyes opened. He turned his head toward the sound of his mother's voice. His baseline stereotypies returned. He began to vocalize. He recognized his parents. He began to eat. He was discharged to home approximately 3 weeks after the initial ECT session, on no antipsychotic medication, and on a maintenance ECT schedule that calls for treatment approximately once a month. He has remained on this regimen since. He has had no recurrent episode of agitation requiring hospitalization. He has had no recurrent episode of catatonia. He has not been re-exposed to antipsychotic medication of any kind. He is at home. His parents continue to care for him. The laminated card with the 3 telephone numbers is back in the pocket of his shirt. The doctor whose name his parents remember is the doctor who administered the electroconvulsive therapy. The consultant who recognized the prodrome on the afternoon of hospital day 4, who stopped the haloperidol before the chart could record what was happening, and who made the diagnosis at the bedside 3 hours later when the syndrome announced itself in the vital signs. That doctor would not meet the family. This is the structure of consultation liaison work. The diagnosis happens at the bedside on an ordinary afternoon, and the patient and his family will not always know whose afternoon it was. Closing. This case illustrates one of the central tensions in psychopharmacology, slightly inverted from its more familiar form. The patient was being treated for an indication for which antipsychotic medication is a standard intervention. The treatment was reasonable in dose and in clinical context. The patient nearly died of it. The clinician's task in cases like this is to recognize the prodrome before the syndrome is established, to stop the offending agent before the chart shows the diagnosis, and to be willing to escalate to interventions outside the standard algorithm when the standard algorithm fails. In a substantial subset of refractory cases, that intervention is electroconvulsive therapy, the oldest somatic treatment in psychiatry, and the one that is asked to do the most when other treatments have failed. This has been a clinical and molecular analysis of neuroleptic malignant syndrome in a patient with autism spectrum disorder. For Psychopharm Archive, I am a consultation liaison psychiatrist and academic physician. Subscribe for our next investigation into the molecules that shape the modern world.